hope I've teed up my colleagues, Dr. Tarita Thomas from Radiation Oncology and Jeff Softman from Medical Oncology, to give us all their wisdom when it comes to using radiation and medical therapies in Merkel cell carcinoma. So Dr. Thomas, you're up first.
Thank you, Dr. Wayne, and thank you all for the opportunity to speak a little bit about radiation therapy. Thank you. We can shift to the next slide. I'm just going to give a little bit of an overview. We've heard some really excellent talks about basal cell, squamous cell. Radiation therapy can be used for those diseases as well as Merkel cell, which I'm going to speak about towards the end of this section. I'm going to give a bit of an overview of radiation in terms of what is radiation therapy, how does it work, what are types of radiation therapy you might encounter as part of your treatment, and what's really involved in getting radiation therapy, and then speak about a particular case that I was involved in. Next slide. Next slide, please. So in terms of radiation therapy is used in about 2/3 of cancers. These cancers that we're talking about tonight, as well as other types of cancers that can happen anywhere in your body. We use radiation either in the definitive treatment, so meaning as the primary treatment sometimes for small basal cells, squamous cells, before surgery or after surgery, which is most commonly the case in Merkel cell carcinoma. Radiation therapy is also used to help relieve symptoms. And radiation is an energy. I'm going to talk a little bit about that in the next few slides. We can also treat some benign conditions with radiation, such as osteoarthritis, plantar fasciitis, ventricular tachycardia. Next slide. So the question is, how does you can move on. How does this energy work? Okay. And what is radiation? Radiation, when you hear that term, many times it can bring different things to mind. Sometimes I just had a patient today say, oh, I thought I would turn into the Incredible Hulk, or, some of the other things that we've witnessed in terms of in society. But radiation is just really an energy source. And energy can come in many different forms. Here's just a pictorial picture of the different types of energy that we encounter from day to day in our daily lives, apart from therapeutic radiation. So we have radio waves, microwaves that we all most likely commonly use, visible, X-rays, UV light, and gamma rays. And then you can think about the size of these particles of energy. Radio waves can be thought of as big as a building. X-rays as small as an atom. So these are really small packets of energy that help to treat cancer. Next slide. And this is the main therapeutic machine that we use. This is called a linear accelerator. So this is a way for us to accelerate electrons to then either cause production of a photon energy source or an electron source that we can use for treatment for things like Merkel cell, basal cell, squamous cell, etc. Next slide. In terms of energy, we have other forms of energy that you may have heard about on either the news or through your own research, including proton energy. Proton energy is a source that we have here at Northwestern in one of our sister hospitals at Central DuPage Hospital that can be used for other types of cancers and rarely, though, in terms of skin cancers. Next slide. Another way to give this type of energy is using MR imaging. So we have an MR machine that can help us image what we need to treat and help us see it better. So, if a patient has metastatic disease, meaning Merkel cell cancer that spread somewhere else, in this case in the liver with the arrow on the red, we can see that a lot much more sharper with an MRI image than with a CT image. Next slide. So how does radiation work? What do these packets of energy really do? Well, radiation causes breaks in DNA of cells that can lead to cell death. And so we know we want to kill tumor cells and we want to preserve normal tissue. And so this is where the radiobiology concept comes in terms of really causing lethal damage versus sublethal damage. Similarly to treatments, as Dr. Chandra has spoken about in terms of medical oncology management, where we're really trying to affect the tumor and preserve normal tissue. Next slide. Types of radiation I've already spoken about in terms of X-rays, gamma rays, electrons, and we also have other ways to use these energy packets like carbon atoms, like cobalt, which we use to treat sometimes patients who have brain metastasis coming from tumors like Merkel cell, sometimes like squamous cell, and other types of cancers. Next slide. In terms of delivery of radiation, I think this is a really important thing to talk about. We have many ways to sculpt the dose of energy to whatever part of the body we want to conform to. So for example, if we're trying to treat a tumor that was on the nose, we can conform to the edge of the nares, the part of the nose that we're breathing out of, okay? If we need to treat somewhere along the jawline, or somewhere along the arm, which happens many times when we're treating our patients with Merkel cell carcinoma. So these terms here are things that you might encounter as you read more about radiation therapy, including intensity modulated radiation therapy. I'll show a slide of that down the road. Go back, please. Okay, and go forward one slide. Thank you. So the role of radiation treatment in Merkel cell carcinoma, Dr. Wayne really set up this talk really in a great way. The majority of time in terms of Merkel cell, we're being asked to see a patient after surgery. So if a patient has had a great resection of the tumor and also has had a sentinel node biopsy, if there are cancer cells in that sentinel node biopsy, we can come in and treat that whole nodal basin. So where that lymph node drains to with radiation to help sterilize where that tumor was. There are other risk factors in terms of needing radiation after surgery. Dr. Stefan spoke a little bit about that in her talk as well. Those include size of the tumor, immunosuppression, location, close or positive margins, and lymphovascular invasion, where there's invasion of some of the dermal lymphatics along where the tumor lies. If a patient is not a surgical candidate, if their disease is unresectable, okay, or if the surgery can cause significant side effects, then we can also think about radiation in a palliative manner to address symptoms of the tumor or try to improve the control of the tumor if it can't be resected. Next slide. So what is involved in receiving radiation therapy? As Dr. Wayne mentioned, we have a very robust interdisciplinary discussion about all our patients who need this type of treatment. And based upon those discussions, if there's a need for adjuvant radiation, meaning after surgery, or if the patient is not a surgical candidate, then they would come to me for a consultation where we would discuss the role of radiation. We'd talk about the planning and the behind the scenes, what happens in terms of getting that complex radiation plan to you. And so this is just a pictorial view of a patient lying down with the different beams of energy coming from different directions to really sculpt around the tumor we need to treat. Next slide. So after the consultation, we then have the radiation planning session. And that's a really important part of the journey through radiation treatment. That's where we really have to create an immobilization for you as the patient to keep you in the most comfortable position in a very uncomfortable situation. So in this case, what you see is a patient lying flat on the table. And here we're most likely addressing a tumor in the thorax, meaning in the lung. And you can see the mobilization device down below. And we need this for consistency, reproducibility, and comfort as a patient undergoes treatment. Next slide. And after the planning session, then a lot of the hard work begins with our team, including PhD level physicists, dosimetrists, therapists. So we all work together, including the physician, to identify the tumor, decide on the dose that needs to go. We already know the dose, but the dose that needs to go to the surrounding areas to preserve the organs in the area where we need to treat. And then before any radiation plan comes to you, we always have a phantom. So that's what you see in the top right, where there's what we would call a phantom, or a fake patient, quote unquote, and we would deliver that treatment to that and verify a lot of quality steps before it comes to the patient, as down below, where there'll be 3 people called therapists who help get you on the table as comfortably as possible, again, in an uncomfortable situation, to get you this treatment. Next slide. This is a patient that was treated who unfortunately had a tumor, a Merkel cell tumor of her elbow. And so she had neoadjuvant therapy, as Dr. Chandra mentioned, that can happen in some of these very complex cases of pembrolizumab, and had actually an excellent response. And then she had a really thorough surgery with Dr. Wayne. And then she came to me for adjuvant radiation due to one of her lymph nodes having disease. And so what you see is her setup here, this cushion that we create around her arm, and immobilization, especially for these tumors that, as Dr. Wayne said, are very rare, really have the best support from a tertiary center that sees a good amount of these cases to really have the expertise for this part of the treatment. The setup is actually very important. And then what you see on the right is the dose that we're trying to deliver to the area from the elbow up through the arm and into the draining lymphatics. And so you see that with the yellow line surrounding the area we want to see in purple. Next slide. So thank you for the opportunity to speak, and please feel free to connect if there are any questions. Thanks.